Okay, so let's talk about miscarriages and abortions. Okay. So we could have something called, and it's a lot of words over here, but they all mean the same thing. A spontaneous abortion, or an SAB, also referred to as a spontaneous termination of pregnancy. It just happens automatically. We didn't induce it. That's also called an STOP. These are miscarriages. So all pregnancy tissue have been expelled without surgical intervention. It just comes out. Okay. This occurs less than 20 weeks of gestation. Most do occur in the first trimester. Okay. It's about 15 to 25% of all pregnancies worldwide. Okay. An incomplete abortion, okay, is some pregnancy tissues are still remaining in the uterus. Okay, and because of that, if there's some particles, there's some products of conception, we call POC, products of conception. If there's some pregnancy tissue that's left in there, in other words, here's a typical case. Woman is pregnant, let's say she's 10 weeks pregnant, she's getting cramps, so she sits on the toilet bowl and she's trying to dissipate or get comfortable with the cramps, and some blood comes out. But some of the blood, there's some tissue there, okay? And she's getting cramps. The reason why you're getting cramps is because for whatever reason, the body doesn't want to have that pregnancy, okay? A lot of times we don't have the answer to it. It's just a bad pregnancy. The number one reason for all miscarriages is trisomy. Just have an extra set of chromosomes. So, and there's just so many things that are wrong with that pregnancy. There's there could be heart defects or abnormalities, neurological defects. So it's Mother Nature's way of saying this pregnancy is not really compatible. Like, let's, eliminate it. So, if all of it comes out, then we call it a spontaneous termination of pregnancy. If some tissue comes out, she's on the toilet bowl, some's coming out, but her body's still trying to reject it by squeezing out all the tissue, and that's why she's getting all those cramps. If some of the tissue stays inside of her, then she'll continue to have cramps and she'll continue to have bleeding going on. We call this an incomplete abortion. So there's pain, cramping, and don't get me wrong, cramping can be very bad, right? I mean, it's really painful. So you get abdominal pain and bleeding. The only thing we could do is that they have to go to the hospital and we have to manually remove the rest of the products, doing what's called D&C. Scrape out whatever's in there so that the blood and the cramping will stop. Okay, so that's what incomplete abortion is. Elective termination of pregnancy, an ETOP, also referred to as a therapeutic abortion. This is where commonly you hear all about, a woman had an abortion, right? This is more of, there is no symptoms for it. In other words, they don't have, it's more of a moral reason why they need to remove the pregnancy. You know what abortions are, right? So this is where the woman that has no symptoms, no bleeding, no cramping, or the pregnancy itself, when they do an ultrasound, there's no fetal heart activity going on. In other words, the baby died, so to say, at, let's say 10 weeks. The heart, there's no fetal activity. Then that is not considered this. If there's a fetal heart that's beating over there and there is no signs and symptoms, then they'll do this abortion, which is more an elective termination of pregnancy. So we'll surgically remove everything. Again, it's through a D&C where same-day surgery, if you don't know much about these, are same-day surgery, where they will put the woman in stirrups and will dilate the cervix to open it up to allow us to get more metal instruments in there to scrape out all the products of conception. And that's how they do that. Okay? Okay, so let's talk a little bit about amniotic fluid. Okay? So we need some fluid around the baby, the amniotic fluid as we call it. And it's there for a number of reasons. One of them is to cushion the baby so that when mom walks, the baby's actually floating in water. Does that make sense? So it's actually kind of fun, I would imagine. It's just floating in water. So if the mother tumbles, trips and falls. I mean, that could be something bad because it causes other things. But more or less, the baby is cushioned by all this fluid. So it's like, whoa, kind of thing, and it's just floating there. Right? So, so we need amniotic fluid there. That allows the umbilical cord that's all around the baby to also be free floating. The baby can move in this water. Okay. If there's something called oligohydramnios, and oligo, if you remember oliguria, right? What is oliguria? A very little amount of urine coming out of the person's body. So, oligohydramnios, oligo means very little amount of water around inside the amniotic sac. That's what that actually means. So we're decreasing the volume. Maybe the fetus doesn't have good kidneys, and it's not peeing, because that's one place that all this water is coming from, is from the baby peeing. So maybe the kidneys are not functioning. But as the pregnancy gets further and further and further on, the baby's getting bigger, and there's going to be less fluid around the baby. So we call this oligohydramnios. So the fetus, and what we're concerned about, is that normally that umbilical cord is floating around the baby. If there's less fluid there, now the umbilical cord is right against the baby's arm. If the baby moves just a little bit, it will compress that, because the uterus is there, it will compress on that umbilical cord. And remember, the umbilical cord has blood vessels that go to the baby, right? The oxygenated blood. So if you compress that, now you're going to have less blood going to the baby, and that can lead to fetal distress and death. So when you have a baby that has very little fluid around him or her, we need to deliver the baby. We call it oligohydramnios. Okay? To the other extreme, like, so here's a large amount. Now, premature poly means a large amount. Okay? So here's a large amount. Now, premature rupture of membranes can occur. Now, what happens here is that if there's so much fluid around the baby, it's like you got this big balloon. Remember, the baby's in a sac, right? The amniotic sac. So if you have this big balloon and it's getting filled up with more and more and more fluid, eventually that balloon is going to burst. Does that make sense, right? So we can have premature, now we're going to talk about this, what this ROM is, but it means rupture of membranes. In other words, your water broke, okay? But you could have premature. If there's too much fluid around the baby at, let's say, 34 weeks, for whatever reason, it'll burst that open. And remember, that sac is very important. That's one of the things that's going to, remember, the vagina is has a lot of bacteria in there. And that sac, that balloon, is keeping the bacteria from entering where the baby is. If that balloon ruptures, now you're going to get a lot of bacteria from the vagina and going into where the baby is, and that can cause an infection. Okay? So what we got to do is, if there is a premature rupture of membrane, we need to act upon it. Okay? We got to see how the baby is going to feel the stress. And again, when that ruptures at, let's say, 33 weeks, our other concern is that now there's a little bit of water around the baby. So again, it could cause this. It could compress on the cord. So we got to keep the mother usually in the hospital until the time of birth, whenever that's going to be. That's where you hear stories that they're in there for, let's say, 10 weeks or whatever they rupture their membranes. Okay? Polyhydramnios is a very common sign that we see with mothers who are diabetic also. So when we see a woman, when they do an ultrasound, they see that there's a lot of fluid around the mother, we are concerned that the mother may be diabetic also. So we just keep that in mind. Polyhydramnios is a sign that the mother could be diabetic, not the baby, but the mother, okay? And that could be because of gestational diabetes that we talked about before. But it's not the only reason for polyhydramnios, but it is one that you should be, that you should know. Okay, let's talk about meconium. Meconium is the first stool that comes from the neonate. So once the baby's born, then the first stool that comes out, we refer to it as meconium. This is usually a thick, green, and sticky stool that comes out. So it passes there. That's what we call it. Now, what we're also concerned about is that sometimes meconium will come out while, like, you know, the baby will poop when they're not even out of the womb yet. And that's a concern for us because, remember, if there's fluid around the baby, or if there's less fluid around there, either way, that meconium can eventually get it in the baby's mouth. This is sticky, thick stuff. We don't want that to go down to where the lungs are, right? We don't want to go down in the trachea. So we're concerned about that, okay? That there's what we call meconium aspiration. So it can mix with the amniotic fluid, it goes into the fetal lungs, and that could be like threatening for the fetus because now you have this thick stuff that's going to, inside the womb is not so much of a problem, but when the baby comes out, when the baby's got to use the lungs to breathe, if there's all that meconium that's in there, we're going to have problems because the baby's not going to be able to breathe properly. So that's what we're concerned about with that. Most cases, the meconium is going to come out after delivery, but there are cases where they deliver during labor, and that's why it's also important to take a look at the fluid and see what color it is. If it's greenish in there, then we're considering meconium. We got to alert the pediatrics that they should be at the delivery, okay? Just to do the suctioning out any of the meconium that's in the trachea they need. Okay? All right, so let's do a little bit more of what I refer to as medical alphabet. The nomenclature problems, okay? So we got these PPP things going on. Not hard to manage, okay? All right, first off, I mentioned to you before what this was, ROM, R-O-M, okay? This means rupture of membranes. In other words, the water broke, right? You heard about that in the movies, or your sister, or your mother, or whatnot, or yourself for that matter. When your water breaks, we refer to it as rupture of membranes, okay? Now, the way it's supposed to be is that you should have contractions and then rupture of membranes. Think about it. Contractions are squeezing on that balloon. And eventually, it's going to squeeze so hard that it's going to pop the balloon and water is going to come out. That's the way it's supposed to be. You have contractions, and then you have rupture of membranes. The way it's supposed to be. Now, we also have something called PROM, premature rupture of membranes. What this means is that they had rupture of membranes, and then she had contractions. That's not normal. Okay? You start questioning what made the water break. Because if it wasn't contractions, she wasn't feeling contractions, then what made that water break? Was it because an infection came from the vagina and went up into the uterus, and sometimes infections can thin down that membrane, the amniotic sac itself, so much that it can actually bore a hole, and then that lets the water out. So did an infection ensue that caused that rupture membrane? Now also I want to mention too that the fluid, the amniotic fluid, actually causes, there's chemicals in there, prostaglandins, that will actually stir up contractions. So that's why normally, if you have contractions and then you have rupture membranes, more likely the contractions are going to get stronger and stronger because that water is now all over the place. The amniotic fluid is all over the place, and it will stir up a lot more contractions because of all the prostaglandins that's in it. So if she ruptures a membrane and then she starts to contract, the contractions are probably coming from the prostaglandins that came from the fluid that's now free, and it's going all over the receptors for the prostaglandins on the uterus. So that's what PROM is. Okay, the first key. Then we can have preterm premature rupture membranes, PPROM. What this means is that they get the rupture membranes happens before 37 weeks. That's preterm, and they occur before contractions. Back to this one. All right? Does that make sense? We're building on it. We also have another P, prolonged preterm premature rupture of membranes. What this means is that they had a rupture of membranes that has lasted longer than 24 hours, and it's before 37 weeks, and it's before the contraction started. Our concern here is that if she ruptured her membranes yesterday morning, and now it's today morning, is that that baby has been exposed. There has not been a boundary or a blockade from the vagina to the baby itself. So there was enough time within 24 hours that there could be a lot more bacteria that could go and ascend into the uterus and cause a major infection. Okay, so in that case, we need to start them on stronger medications. Okay, antibiotics, and this is obviously a risk for infection. All right, so questions about nomenclature, rupture membranes, all the different abbreviations here? Okay? All right. So let's talk about some complications now. So we could have placental and cord complications. So here we have placenta previa. And what that means is that their placenta, now normally the placenta should be away, so let me just put this in perspective. Here's the uterus. Obviously, the baby's inside the uterus. Here's the cervix, the opening to the uterus, and this is the vagina. Okay? Normally, this placenta, when this baby's bigger, the placenta is someplace up here. It is not the placenta does not go over where the cervix is. If it does, then there could be some bleeding that can happen from the placenta. Usually in a case like this, they're usually in their third trimester, okay? And they, so it's after 24 weeks, so, or 28 weeks, but they usually have what we call painless bleeding. It's like, wow, where's all this blood coming from? But they're usually not having pain, okay? The blood is usually just coming over here. If the blood is touching the uterus, we tend to see a lot more cramping and pain going there, but we don't usually see it often with the placenta previa. Placenta previa means before, right? Previa, before. So what they're saying is the placenta is happening at the doorway before the baby. So that's what we say, placenta previa, okay? So basically, in a case like this, a lot of times as the baby grows, this placenta, like this uterus gets bigger, and this placenta kind of moves up because it's being stretched. It's not that it's moving; it's just as the uterus is stretching, this placenta kind of stretches with it and moves away from the cervical osses. Okay. In most cases, we just have to observe them. They could it's usually bed rest. Nothing per vagina, so not putting so sexual intercourse is not permitted for something like this. Just bed rest. If the placenta is still there at the time of labor, you can't deliver the placenta before you deliver the baby. So in a case like this, they will need to have a C-section and remove the baby abdominally. Okay, they don't have to. They can't deliver the baby vaginally. Okay, so that's placenta previa. Okay, the placenta occurs before the baby. They get painless bleeding, and it usually occurs in the third trimester. Okay? So this is just showing a picture of that. All right, here's the uterus, of course. A baby would normally sit here. Here's a placenta previa. So here's the cervix, and the vagina will be over here. Here's showing you where a placenta would be before the baby. Does that make sense? Can you visualize that? Okay? So that's placenta previa. All right, let's talk about placenta abruptio. This means that for some reason the placenta has separated off of the uterus. That could be due to trauma. A woman went through, had a motor vehicle accident, tumbled and fall, domestic violence, or it could just happen spontaneously. This here is where in the third trimester, again, they will get usually painful vaginal bleeding. They're getting cramping going on, and blood is coming out. Okay? This is, in cases like this, we just have to do an emergency C-section. Even if it's 33 weeks, we're going to lose the pregnancy. Depending on how bad it is, we just have to do that. So that's the separation of placenta from the uterine wall. Okay? Then we have placenta accreta. Placenta accreta is that, remember, when we have the placenta, oh here, so here's the uterus, okay, and we have, this is the endometrial line, and then the rest of this thick muscle is the myometrium. We have the myometrium. The green here is going to be the endometrium. Here's the cervix, and of course here's the vagina. Right? So what happens with placenta accreta is that the placenta, now keep in mind, the placenta should only be going into the greens. That's how it's attached to the greens. Because the endometrium, as in a non-pregnant state, that's the part that sloughs off your menstruations. So the thing that comes off is all the green, it sheds off, and then we've got another green that's coming on. But in the case of placenta accreta, when this placenta was developing on the endometrium, it went further and it went into the myometrium. That's a problem. Because when that placenta needs to come out, it's glued, stuck to the uterus. Because we can't remove the myometrium, the muscle layer of the uterus. It would have to be a part of just the green here. We have a big problem. You wouldn't even realize this until the time of delivery. Okay? So the placenta implants into the myometrium, and it can't be delivered for the third stage of labor, right? So the placenta delivered, so here you're waiting for the placenta to come out. Remember those times, 30 minutes if it's multiparous, up to an hour for nulliparous. If it's going longer for, let's say, multiparous, someone who's supposed to, it should have delivered in 30 minutes, and we're going on to 45 minutes, an hour. We got to start thinking, is this the reason for it? Okay? And we might have to go in, reach all the way into the uterus, okay? Load her up with a lot of pain medication. We go inside and we try to manually remove that placenta. But if it comes out in pieces, I can't get a whole placenta there. That's suggestive that there's probably placenta accreta that's going on, that it can't shed off. Okay, it's just coming out. I can't take it as a one big piece. So the reason why this would happen is a woman who had many scars on the uterus. And when I mean scars, if they had to remove, let's say, fibroids from the past, they had to remove a lot of fibroids from these uterus. There's a lot of scars on there. Or what more commonly that we see is that the more placentas that have been on that uterus for her lifetime, when we remove the placenta, it leaves a scarred area there. So here you have someone who might have had, let's say, 4 scarred areas because she was pregnant 4 times, whether miscarriages, abortions, let alone if you had to do a miscarriage abortion, you had to scrape out. That would also cause scarring inside the uterus. The scarring itself means that placenta could easily go through here normally, but if there's a scar there, it didn't. The anatomy of the endometrium is debunked. It's not normal anymore. So now the placenta that wants to implant on the uterus finds other ways and finds ways to go beyond the endometrium and goes deeper because there's been little openings there from the scarring. Does that make sense? Okay. So that's what's happening. If you see a woman that's had multiple pregnancies, whether they were vaginal deliveries or C-sections, abortions, miscarriages, any kind of scraping, if there's someone who had possibly many scars on the lining of the uterus, the endometrium, that they're set up for a placenta accreta. Now, biggest problem with this, the complications, is the retained placenta. Remember, that uterus is not going to be able to involute to a small size. That woman is going to continuously bleed. And there's nothing you could do with something like that unless, because that causes a severe postpartum hemorrhage. The only thing we could do to delay the death of the woman is to do an emergency C-section. Emergency hysterectomy. In other words, remove her uterus. Okay, so we gotta do the C-section, remove the baby. Baby should be fine. Okay, placenta's still, well, if the placenta's still in there, that's what I'm saying. If there's, okay, baby came out, placenta's still there. Okay, if we know that a woman has a lot of scars on it, that there's a great chance that she may have a placenta accreta, we could predict that from happening by just knowing the woman's history. And we talk to the woman and say, look, there might be a problem with removing the placenta. You had, let's say, 8 pregnancies before. We'd rather do a C-section. If we do a C-section, remove the baby, we may have to do a hysterectomy, which means that we have to remove the uterus. And the only purpose of the uterus is to hold babies. So if we do that, it's pretty drastic. She'll never have a baby again, obviously. But it's the only thing to save her from her life. Does that make sense? All right? Because the placenta, you just can't remove. You'll be destroying the uterus. And you wouldn't want another placenta to be there for a future pregnancy anyway, because she's had the placenta accreta before. Okay? So placenta accreta is pretty bad. We're going to remove the uterus. It's called a hysterectomy. And what we got over here is an example, right? This would be part of the placenta, and you can see it actually involuting, going right into the muscle, into the myometrium. It's going full scale. It should only stay on this part. It should not go further into the myometrium. We call that placenta accreta. Okay? All right. So away from the placentas, let's just talk briefly about cord problems, so umbilical cord problems. We see this quite often on nuchal cord. Nuchal means neck. So this is the umbilical cord wrapped around the baby's neck. It could be that there was a very active baby doing somersaults and stuff and just getting literally tangled up in the umbilical cord. The problem is when the baby comes out, it could be, the head pops out, the placenta's still there, so it could be pulling on the cord. If it does, it can kink that, the umbilical cord not having a lot of fluid, a lot of oxygenated blood going to the baby. So we'll see that possibly on the fetal strip, or the fetal heart rate. Not something you would be concerned about, but we have ways that we can predict that's what's happening too. So what happens is when the baby comes out, the baby's head comes out, one of the first things we do, we feel around the neck to see if there's an umbilical cord that's around there. If there is, then we're going to cut the umbilical cord right there so that there won't be any kind of problems having the baby being delivered. Okay? So, or it could be another reason why this might happen is because the umbilical cord for some reason is very long. So there's a lot more cord around there. Sometimes the baby could be so so active. We could also have something called a true knot. And you can see it over here in the umbilical cord. You can see the baby was tumbling and doing around. Luckily, it wasn't going around the baby's neck, but instead it goes around and forms a knot on the umbilical cord. This, of course, same way as kinking. If you have blood flow going through here, if this gets too tight, that can actually stop any blood flow going through there. So, and my cousin actually, her child had 3 knots around there. So she was just lucky with all that. But again, when he's doing these knots, they can kink the bloodstream or the blood vessels, deferring any blood going to the baby. Okay.